Welcome everyone to Changing Care in the Era of Trikafta at ResearchCon. My name is Jackie Schoberg and I am an adult living with CF. I am very active in the CF community as a research advocate representing the patient point of view, and I will be your moderator for this session of this evening. I'll be introducing our other speakers in just a moment, but before we get started with this session, I wanted to go over a few housekeeping items related to technology so we all know how we can interact. First off, I want to tell you all that we will be running polls throughout this session. There's a little icon with like 3 little bars on it, and that's what you'll see when the polls go live, and we'll have multiple ones throughout the session, so watch for when they end and new ones pop up. We'll also be taking audience questions and answering them at the end of this session. And to submit your questions, please use the Q&A button. There is a chat feature during this session where you can chat with among all the patrons here, but the main questions, if you want them to get to us, you need to use the Q&A button because those are the ones we'll be monitoring. And please, when thinking about your questions, formulate it in a way that is helpful to everyone, because we really cannot address individual treatments or diagnosis plans. During this whole presentation, we encourage you to take notes and write down questions that you agree with, and we will do our best to answer as many as possible, but some of these may need to be brought up with your care team after the session is over. You'll also notice that if you, in the Q&A, I got sidetracked. In the Q&A, if you do find a question that you relate with and you want to see answered, go ahead and like that one for us so we know which ones you all are wanting to get more attention to. As always, this is meant to be a safe place, so please you express your opinions, but keep the chat language clean, respectful, and preferably on topic. And please refrain from giving any medical advice. If you should have any technology issues during the session, you need to go back out to the main format and look for the tech and support room on the home screen of the event. And it looks kind of like a lab. Okay, with all that out of the way, I would like to take a minute to introduce the other speakers we have for this session tonight. First, we have Kathy Sabadosa. She is the Director of Quality Improvement and Innovation at the Cystic Fibrosis Foundation. There, she executes a national quality improvement effort by engaging healthcare professionals, parents, and individuals with CF at 268 CF-accredited programs. Prior to joining the CF Foundation, she was a member of the research faculty at Dartmouth Institute, where she served as the Senior Research Director. Kathy is also a parent of an adult with CF, so she has a little double knowledge over there. Excuse me. We also have with us Dave Nichols. He's an associate professor of pediatrics at Seattle Children's Hospital at the University of Washington and the medical director of the Coordinating Center for the CF Therapeutics Development Network, also known as TDN. He has provided CF medical care for both adults and children with CF for several years, and now helps to support and lead a number of CF clinical research trials. His primary academic interests focus on understanding how best to use the tools and therapies that have been developed for people with CF. This includes ongoing or upcoming studies, testing whether certain drugs should be used in combination, how the modulator drugs will affect a number of organ systems in the body, and whether certain existing therapies can be reduced in people who have large health improvements after starting modulator drugs. Dave also supports a variety of programs to foster or enhance careers in CF research. Now that you know a little bit about us, let's get into why we're here today. Today, we'll be talking a lot about how Trikafta is affecting the health of people with CF and how treatments and therapies are changing already. We'll also talk a bit about how we determine which treatments are most important and which might be able to take a back seat, especially as modulators become more widespread. I would now like to turn the mic over to Dave and Kathy, who will give us a little bit of background into modulator therapies. So let's start with you, Dave. Thank you.
Thanks, Jackie, very much. And it's great to be with you all. So let's begin just with a little bit of level setting to quickly review what we know about the effects of Trikafta so far, starting with the trials that were run by the sponsor Vertex Pharmaceuticals. These were large, well-designed studies, including several hundred people with CF. I'm sure many of you were involved in these studies, and we thank you for that. So what I'm going to show you are some of the more typical or traditional outcome measures that we include in clinical trials, beginning with sweat chloride here, and we'll benchmark the Trikafta effects against some of the more familiar drugs. Top, we have ivacaftor alone in the most responsive population, those with G551D mutation. And then we have the two drug combinations, Orkambi or Symdeko. What you can see is the biological effect, or the change that we used, the biomarker we use in clinical trials to look at the effect on CFTR, the sweat chloride change, was significantly improved in those who began Trikafta. So we saw improvements of between 40 and 45 points. In other words, a reduction toward normal in their sweat chloride value. Recognize that those at the bottom, those on Trikafta in the trial who came from Symdeko, one of the two drug combinations, this was an added further benefit. We think about improvement in lung function measured by FEV1% of predicted. You can see, again, very nice improvements in the lung function in people who were otherwise stable during their participation in the study. So these are above their baseline for the most part. Increases of 14% in those who were beginning on no modulator, those with just one copy of the F508del mutation, and increases in an additional 10% in those who were coming from Symdeko. The risk of exacerbation was also dramatically lessened by nearly 2/3 in those who had one copy of 508 who started Trikafta coming from no modulator drug, to be determined in those who are homozygous shifting from Symdeko to Trikafta, but likely again significant improvements, and respiratory symptoms measured by one of our patient-reported outcomes show dramatic improvements or reduction in those respiratory symptoms typical of CF. Even better than we saw with Kalydeco studies or ivacaftor alone in that smaller population. It's interesting to think also about whether or not these drugs may improve the function of the pancreas. And so we have some early data coming out from studies where effective modulator therapy, in this case ivacaftor alone or Kalydeco, was started early in life in those with G551D mutation. You can see here when the drug was started in a small number of individuals between the age of 1 and 2 years, their pancreatic function as measured by fecal elastase went from abnormal or below that threshold shown in the dotted line to above that threshold, where the majority of them reached what would be defined as pancreatic sufficient. When the drug was introduced at somewhat later point in life, age 2 to 5 years, there were still many who seemed to shift from pancreatic insufficient near the bottom of this figure to a range near or even above that red dashed line, suggesting that there may be a potential to preserve or even recover pancreatic function if highly effective drugs are started early enough in life. And I think that's very exciting. But beyond that, and beyond these more typical studies done to extend drug availability, there are a number of other additional trials funded by the CF Foundation that will look broadly at a number of other aspects of health that may improve with these drugs. One study that many of you may already be part of is PROMISE, where we've enrolled nearly 500 individuals with CF who've recently started Trikafta and are using the expertise of a large number of investigators across the U.S. to study a range of questions, including whether or not this therapy may improve liver function, how it may impact growth and body composition, how it may impact the risk of developing CF-related diabetes, how it may change the microbiology in the airway and the intestines, how those GI symptoms may improve and transit time may improve in the intestines, etc. So we're very excited to learn from this. This is a 2-year-long study, and we really appreciate all of you who are involved in that now. But that's just a backbone for a large number of studies, and I'm only showing you some of them that will focus on really understanding how highly effective modulator drugs improve the health and quality of life of individuals with CF. Very briefly, I'll just mention that the CHECK-SC study is helping us understand in large groups or large numbers of patients how improvements in that sweat chloride measurement can associate or possibly predict improvements in health. The BEGIN study will examine what happens when we start these drugs very early in life, in the first couple of years. Excuse me. And so I think that really shifts the question to what can be prevented as opposed to what can be corrected. The SIMPLIFY study is expected to begin this summer or perhaps fall, and we'll be assessing whether or not people who are doing really well on Trikafta can do about as well in regards to lung function or their symptoms if they're allowed to stop one of their chronic therapies, such as hypertonic saline or pulmozyme. And the QUEST study will then examine how patients' attitudes and beliefs around pulling back on some of those therapies impact how it was for them, their experience in being in a study of withdrawal, because withdrawal studies are atypical for us and a new area of exploration. With that, I'll turn it over to Kathy to talk about some more exciting work.
Hi, everyone. Good evening. It's great to join you. I'm going to talk a little bit about some studies that we're doing out in the field of what we're calling real-world research to learn from people with CF and their families about how what they're doing at home is having impact on their health, particularly around people who are using Trikafta. The first study I wanted to share with you we called HERO. It's a home-reported outcome study. The objective of this study was really to gather whether patients and families were willing to consent to have their data used in a research study. This was done on a phone or a mobile application, and we wondered if people would consent, not being outside a clinic, but instead agreeing to use this platform and consent to give their data to the platform that we were using. The second objective of the study was to assess the consistency of the data that was entered over the 6-week period of the study. And this was everything from tracking maybe daily medications people were taking, symptoms they were experiencing. We wanted to see how often people were willing to enter that data into the application, and then to understand what treatments people were using over and how that varied over time over the 6 weeks of the study. We all know, I know myself, my family, we're not perfect every day. We wanted to see the patterns that emerged from collecting that data. And then finally, we wanted to link that data to the registry to see how what was captured in the CF Foundation patient registry compared to what people were reporting at home in their everyday life. Can you advance to the next slide, Dave? This is what the application looks like. It's Folia. There's some resources that are available to you back on the platform that you can take a look at it. Again, it's on a mobile phone. It's very easy to use. It's literally tapping 1 or 2 questions every day. And it's also, you can customize it and track what you need to track and what's important to you. So we thought this was a great platform to begin to understand what's going on in the real world. Next slide, Dave. I wanted to share with you some of the findings that we had in the study. 63 people ended up enrolling, and they represented 23 states. The patient count was we had 35 people under the age of 12, 10 between 12 and 18 years of age, and 18 people over 18 years. 75% of the people who participated in the study tracked at least once during the day and were able to collect information. And then 77% of people were active over the entire 6 weeks of the study. So we were really pleased to see that people were very engaged and wanting to share their information and track what was going on day to day in their lives. What did people track when they were on the platform? The top things that were tracked were airway clearance use, Dornase alpha, hypertonic saline. Reasons why people weren't putting that data into the study were they didn't have time, they weren't feeling well, or they wanted to take a break from it. There were over 3,000 symptoms observed, and what was some of the top tracked symptoms included bowel movements, coughing, postnasal drip, loss of appetite, and stomach aches. And you can see there was a whole variety of other symptoms that were tracked over the course of the study as well. Again, people with CF and their families were able to customize what they were tracking. We didn't ask for them to specify any particular symptom or treatment. I want to share with you, next slide, what happened in the post-study. We did do an evaluation of the platform itself. People were tracking previous to us introducing a platform into their lives. So people were very interested in tracking their symptoms at home. Many had some homegrown systems that they had put into place, such as paper or notebooks or spreadsheets or mental notes. So it was really good to see that people were already doing a lot of this work and wanted to continue with this work. The other study that I wanted to share with you tonight is from the CF Learning Network. That's a group of 40 CF programs around the country that gather to do quality improvement work. Well, one of the centers in that in the Learning Network, we approached about doing a particular real-world research intervention and asking people their thoughts around potentially reducing or stopping therapies now that they were on highly effective modulators. There were two arms to this study. We gave a survey to the clinicians that were part of the 40 programs in the CF Learning Network, and we asked to understand their current practice, their assessment of a study design, and we wanted multidisciplinary input from all the care team members that were part of the CFLN. The site that we worked with was Riley Children's in Indiana. We asked the patients and families, again, at that center, to fill out a survey as well and have their data that they reported to us linked back to the CF registry. And we wanted to understand their point of view around current treatments, barriers to maintaining treatments, and comfort with real-world research studies. If you can go to the next slide, Dave. I just want to show you a slice of what the population looked like that participated in the study. About 60% of their patients, or just under that, were on a particular modulator in the Indiana study. So we had a nice 114 folks that participated, and we had a really great turnout of clinicians that reported in the study. Physicians, nurses, social workers, therapists, mental health coordinators, and some pharmacists all answered the survey. If you want to go to the next slide. This is the result that surprised us the most at the end of the study. You can see on the left-hand side, patients and families. The gray bar represents not interested in stopping therapies. The green bar is somewhat interested, and the last purple one is very interested. To our surprise, clinicians were much more likely and inclined to want to have people participate in studies about withdrawing therapies than patients and families were at the Indiana University and Riley Children's. So to our surprise, we thought patients would be more interested, but it actually turned out that the clinicians were much more interested in this. So you can see also the therapies are listed: hypertonic saline, Dornier alpha, all the chronic therapies. Again, a big surprise to us. So this is just the beginning of what we're learning directly from the field. We're going to have a second study called HERO 2 that'll be starting up and doing something very similar to HERO 1. Now that we did sort of a proof of concept, we're hoping to involve more people in that study. So I'll stop there. Thank you.
Thank you so much, Dave and Kathy. That was a lot of really great information and some very exciting research happening for the CF community. Now is the part of the presentation where I would like to open it up for discussion for questions and answers. Keep in mind that some of them we pre-answered because they were submitted when everyone registered. But before we get into all that, we're already noticing that there is a lot of questions about this HERO study that you just mentioned, Kathy. So how do people get involved with this project and find more information about it?
That's a great question. For HERO 2, we have a study design team that we've pulled together and a project team, and we're going to launch a design day coming up later this spring, and then we'll put a call out for programs that are interested in participating.
Wonderful, wonderful. That is so great to hear. Now, please remember to keep submitting those Q&As through the link, and keep those eyes out for the new polls that pop up. We closed our first one, and we'll be starting another one very, very shortly. They only stay up for a few minutes, and then we move on to the next. So just keep an eye on that while we're doing this little session. Now, the first question that we had submitted was a question of eligibility. So, Dave, can you tell us what are the actual qualifications to be put on Trikafta?
Sure. So eligibility is really based on FDA approval at this point, and so age 12 and above with one or more copies of the F508del mutation. I do see a question that's popped up now with several likes. Will Trikafta become available to those who don't have that mutation, a delta F508 mutation? And the answer is we certainly hope so. That alone, one or more copies covers a large proportion, 90%, but there's still a significant number of individuals there who are not eligible for Trikafta. Some of that will improve as age eligibility improves, meaning if ongoing studies that are finishing up now are positive and the FDA approves to extend that down initially to age 6 and above, and then perhaps even lower, that will improve overall coverage. There are efforts underway to try to understand whether or not Trikafta may improve function in those who have what might be called rare or ultra-rare mutations. And so, yes, there is some hope that will happen, but I think time will tell going forward when that may occur.
Great. All right. Well, the next question that we had, I've seen a lot, and I've even asked myself, what treatments have people actually stopped since starting Trikafta? Because I know I would love to drop treatments, but at the same time, I don't want to mess with what's working. So how is this being addressed? Maybe Kathy, you have some answers?
Yeah, that's a great question, and I think it's one that it's really hard to answer that right now because I think people are having very different responses to Trikafta. People have very different thresholds for wanting to sort of rock the boat and change up therapies. I think what we're hoping to learn in HERO is sort of what are the natural patterns of that. And I think Dave in Simplify is wanting to look from a safety perspective. Is it safe to go on and off some of these therapies, right? And will it have an impact? So I don't think we really know the answer to that yet, but I think these two studies from the ground up and from top down, or if you want, will help us start to get at the answers to that question, because I think it's very individualized at this point, what people personally prefer to do and what they're comfortable doing in contact with their clinician as well. Yeah.
It's certainly a lot to consider and something I plan on talking to my care team about, but it's just where to start. So another one that we've been looking at is how do we gauge which treatments can be lessened with Trikafta? We had one participant write in that, I know I'm noticing my vest feels like it's becoming less and less necessary. I say this because on the weekends I can get up and do things before even putting it on. I was starting to think that it's time to ask my care team about moving to one time a day or even every other day. So with that in mind, if the research starts to show a trend toward reduced therapies actually working, how will this impact the overall CF patient treatment regimen, and how will research determine what medications will still remain critical to a patient and which ones to take out and why? Where do we even start? I realize I just dumped a whole bunch of questions on you because kind of all lumped into one in our chat discussions too. So Kathy and Dave, can you start to unpack some of these groups of questions that we have coming in?
I'll let you start, Dave.
Yeah, thanks, Kathy. Well, I want to begin by just stating that there are many people who have come together to help put together the Simplify study, and I want to specifically call out Nicole Hamblett and Alex Gifford, who are my co-lead investigators on the study in our team at the TDN. But there was a lot of work that went in combination with the foundation to try to gauge interest level, not only among patients and families, but also providers. And so we surveyed several hundred people in both camps, so to speak. And we decided that for a first study, testing withdrawal of hypertonic saline or Dornase alpha, otherwise known as Pulmozyme, was the one that made the most sense because it's where, at least in our survey results, the interest level of people with CF and their families coincided with interest and comfort level with providers to start there. You referenced airway clearance in the question that came in, and I think that's very interesting and exciting to think about. But for those of us who are working on clinical trials, research, and outcomes, it's a tougher one because airway clearance activities or modalities are not all the same. They differ more than drugs like pulmozyme, for example. And so how we measure the effect of pulling back on some of that is harder to do in our type of research. So that wasn't the first one we chose.
And I'll just add, I think in the HERO study and in the trial that we did with Indiana University, you saw the data. Patients and families were a little bit more hesitant to rock the boat. We heard anecdotally from parents who, if my teen decides to stop something, start experimenting, and then needs to go back on something, habits slip, right? So there was a lot of concern about how do we make the right decisions? How do we make decisions that are going to be good for our overall long health, particularly among parents, right? I think there was some concern around that. What I love about the HERO study is that if we are able to collect from people's everyday habits and what they're doing at home, could we pool all of that information together and start to learn about the impact of, exercise or other things that people might be doing in their life that are on Trikafta? It's just going to give us a look at sort of the real lives of people and across many people if we can design a study that way.
I'm sure it's very hard for you all to narrow down which ones are going to be best to alter when you really don't know, since everything's been tested with everything in place. So I really appreciate all of you all just taking the time to tease out and do this responsibly to figure out what is going to be best for everyone. So I know we've been talking about pulmozyme and which ones to take off, but I do want to switch gears just slightly because I've seen it going through the questions and answers also, and some of the questions that were submitted kind of focus on GI questions, especially with the liver. So let's see, what one did I see that made me pick that out? So somebody wrote in that their son has stopped taking Miralax daily because he feels that he has no need for it. Are Trikafta patients still needing pancreatic enzymes? And have you seen improvements with blood sugar control and digestion issues on Trikafta? I think, Kathy, you might have some insight into this.
That's a great question. It's one that my son has, I have noticed, he is an adult, him not taking his Miralax as often. He's still taking his enzymes, but he's saying he doesn't feel he needs it. And again, I think that's great, but we encourage him to be very upfront with his clinicians, talk to his doctors about it, keep track of his symptoms. Again, I think we still need data on it. And some of this data that we're going to get out of HERO and HERO 2, that's going to start to tell us what is possible. But it's definitely something that I know from personal experience he's reporting, I don't feel like I need it anymore. But I'm worried about the long-term implications. I'm still a mom. Dave, what are your thoughts on that?
Yeah, well, I would be careful about, as you said, trying too much of this on your own, especially with enzymes. As I'm sure many people know, there can be pretty severe complications that can occur if your intestines get backed up and not working well, DOS in particular. And we do have an assay, a test, that fecal elastase, and we are measuring any impact on fecal elastase in PROMISE. So those who are 12 years and older, is there any change or improvement in that? I will say I'm not terribly optimistic that at that point in life, starting Trikafta will lead to significant improvements. And I wonder if this improved symptom pattern or feeling better and perhaps not feeling quite so dependent on enzymes is that the enzymes may be working better, perhaps due to improvements in the pH or the acid-base status in the gut, which is something we have learned about the benefit of these drugs. So to summarize, I think that enzymes are likely still going to be needed when these drugs are started at somewhat older ages, but but perhaps there's an increased safety margin, so to speak, with some of that, and perhaps lesser doses can be found for some people.
That really makes a lot of sense. So we'll see what happens. Sometimes you just can't stop those. Okay. So let's move on to one of the big hot topics that keeps coming up is side effects and generalized other effects on the body. One that keeps coming up, is there a research study planned for the side effects of Trikafta, and especially with the effects on the liver?
Yeah, so kind of two parts, right? So is there a study to assess the side effects? I would say that the initial studies that were done, the placebo-controlled studies in particular, included several hundred people with CF who either got placebo or what is now Trikafta. That's the best way we can try to understand what are side effects and what may be just effects of having CF or general life, because we have a blinded comparison group. Unfortunately, those studies can't often be long enough to appreciate what may develop later. And so there are observational studies, and the company, will continue to collect notable poor outcomes or severe adverse events, as it's termed. We are not focused on safety or poor outcomes in studies like PROMISE. That's not really the focus of what we do there. We are trying to understand, though, if perhaps drugs like Trikafta might improve liver function in people with CF or liver stiffness over time. So we will be looking more at that. I think quickly to the other aspect, or the other part of that question is what about those people who don't seem to be able to tolerate Trikafta? Their liver enzymes, for example, may go very high, and their provider recommends that they stop the drug. That is a known potential side effect, and it's unfortunate. We're happy to see that the rates of that, at least in the trials so far, have been relatively low and even lower than we saw with some of the other drugs that came before. But that does definitely occur, and that's an unfortunate situation. And I think that's part of the rationale why foundation and academic investigators and sponsors around the world continue to work to develop new modulators that may work for such individuals, or why there's a big focus on gene therapy approaches, the topic of the plenary, to approach this issue with in another direction.
I'm noticing, Jackie, a lot of chats in the questions. I'm thinking, I would say talk to your clinicians. One thing I've always done with my son is your CF care team can only help you if they really know what's going on and what you're experimenting with at home. So I can't encourage people enough to have these conversations and be transparent with their care team about what they're doing and what they're not doing. I think honesty is the best policy in many cases.
Yeah, I know me personally, having tried both Orkambi, Symdeko, Trikafta, and been on trials for all three, that there is such a range of things that happen to your body that I don't know what's a reaction, what's a side effect, so like you said, I keep a journal, and every time I bring it up with my clinicians, and we form a plan and try to tease out what's all going on with all of this stuff, because everything is so brand new. So it's really crazy. But yeah, using your care teams is priority one to get all this straightened out. So unless you all have anything else to add, I was going to move on to our next question. Are we good? All right. So we had another person write in that her son's lung function took a dive, and they had to go off of Trikafta, not due to liver, just because of lung function. So now they're worried that they'll have to wait for that miracle cure treatment that's meant for that last 10% that we just can't reach. So for those that had unexpected bad side effects from Trikafta, what is the next step for them?
Kathy, I'm willing to start, but please jump in.
No, you go ahead.
Not an easy question, right? And it starts to lean a little bit into individual recommendations. So I want to be careful that I'm not speaking directly to the individual who sent that very good question. Uh, Even in trials, there's a wide range of outcomes or response to being in the trial. Lung function generally went up, but in some individuals it did not change or even went down. That is not what would be expected by improving CFTR function through this drug therapy, and so one, could consider whether or not a retrial of a drug like that at another time might be useful. I think it's interesting to think about what other confounders, we call them, or other conditions may have contributed to that decline in lung function. But perhaps that actually was caused by the drug, and that would be unfortunate and similar to those who just can't tolerate the drug because of increased liver irritation, for example.
Did you have anything you wanted to add, Kathy, or did that pretty much sum up your thoughts also?
Yeah, I think I agree with Dave.
Wonderful. So one of the other questions that we were seeing is like one of hope. And the question came in as, my son is 2.5 years old. Are we seeing in an era, sorry, let me start that one over because I'm reading it wrong. My son is 2.5 years. We are seeing an era in the next decade where we won't see hospitalizations before adulthood or won't need vest therapy. So is there a significant change in the CF care model anticipated as a result of Trikafta, and could it happen soon?
I'll take that one. I think over the next year, I think we're going to want to keep our care model together. I think we heard in some earlier sessions tonight that people really do value their care team and seeing that care team and having contact with them. I know these modulators are great. Maybe we won't end up going to clinic as often. Now we're all going to clinic via telehealth. So the model, I think, will definitely change, but I think we're going to want to keep it intact and keep that expertise together. So I think keeping those conversations going, keeping the lines of communication going is how we're going to learn in this new era. As you said, Jackie, there's so many things changing and so many things that we want to keep that care team together to help us do that.
Yeah, I just want to echo, that point, which Kathy made well, which is that, we still lack a lot of long-term outcome information about this. The studies that produce such wonderful results were done, as you said, Jackie, before, in the context of continuing all of these pre-existing therapies that have been so useful for a long time. And it would be a real shame, I think, to miss out on the best benefits we can get from a great drug like the modulators if we at the same time start pulling back on other therapies that are still effective. I think we still have quite a bit to learn there. And I think that same thing can be said for pulling back on regular care visits and care models that have also been important in improving the lives of people with CF for a long time. We do understand and share that goal of reducing burden of care overall, but we want to do that, I think, carefully.
Yeah, that's wonderful, wonderful. So we've been monitoring the Q&A just like we promised, and we're starting to see some new questions that I wanted to throw out to y'all and see what you think. So one that we're monitoring right now is, should Trikafta be considered for post-lung transplant patients? Now, this one I have no experience with, so can one of you help me out?
Dave, I think you're probably probably closest to this than I am.
I'm not a transplant expert, and that's full disclosure. But I am aware of conversations around what is the role of a highly effective modulator such as Trikafta in people either pre or post-transplant. So two things. One, there are some anecdotal data, and I think even studies emerging suggesting that those who were likely going to need a transplant in the short term, once they went on Trikafta, many of them seem to have stabilized or even improved enough to hopefully postpone that need for some time. Two, there are questions around improving sinuses in particular. We know somewhat less about the improvements in sinuses as compared with the lungs, but it does seem that these highly effective modulator drugs really can clear up sinus disease in many people, and that sinus disease is thought to be a source of infection in that new lung that gets put in. And so there may be an important role and benefit in trying to address that. Post-transplant, it becomes more complicated because of potential drug interactions with many of the therapies used to prevent rejection of that new lung. And so those decisions become more complicated, but that's not to say that one couldn't get around that with some clever drug dosing. So the short answer is yes, there may be a role, but there's still a lot to learn, and one has to be very careful given all the other drug therapies that are needed after transplant.
We really appreciate your insight, Dave. I know that's not necessarily your specialty, but I know you hear a lot of other clinicians talking about it. So just having your experience and insight really helps a lot of us. So thank you. This one is probably another one for you that we're seeing in the Q&A is, what are the eligibility criteria for the simplified trial? If some patients can discontinue, will it be possible to make more specific recommendations about who and who can't change their treatments over time?
So I want to say that the Simplify trial, while far along in development, the protocol, the design itself is not entirely finalized. So I'm reluctant to comment specifically about inclusion criteria or those who can and cannot participate. But I will say that we want to study what would be a logical group, meaning those who are on Trikafta and have stabilized on that new therapy, who they themselves, their family, and their clinical provider think it may be reasonable for them to be in a study where their drug, such as pulmozyme or hypertonic saline, could be withdrawn for a period of time, perhaps 6 weeks or so. So that's generally who we'll look to study. We also want to make sure that people coming into the study have been using that drug, because if we randomize them to stop and nobody's taking it anyway, we won't learn anything, right? So we'll have to monitor some of that use leading up to Simplify. I will put in one quick plug. If there are those out there who share this interest with us and really learning whether or not people do about the same if they come off of therapy, and they're willing to stick with their current routine for a while for the most part, that will allow us to do that study more quickly. So we appreciate all of you who may participate with us in the months ahead.
The good news.
Go ahead.
No,
after that call for Hero 2, we'll take you.
Yeah.
Based on the poll, it looks like everybody's staying pretty level with their treatments with COVID being around. So that's a good start. So Dave, you did say that the study is pretty well into working. When do you expect to have the results from that study?
Yeah, that's hard. That's hard to predict. It depends on how quickly we can enroll and complete the study and get the analyses. But it will, by necessity, and I'll again compliment the statistical experts such as Nicole who've been critical in designing it. By necessity, it needs to be a large study so we can really understand if people do about the same if they're randomized to stop as opposed to continue a drug. And so it'll take a little longer to fill that study. The study itself is anticipated to be pretty quick, several weeks. So it's not like PROMISE, which is a 2-year study, right? But all that being said, we're at least a year or so out, and perhaps a couple years from really knowing all the fine details of those results. I would think, yeah.
Yeah, I'm loving all this information. I'm taking notes too over here for me to bring up with my care team because I'm learning
Kathy,
as I go too.
Kathy, can you comment at all when you might think that Hero 2 will kind of launch and we'll get some results?
Yeah, we're hoping to launch Hero 2 later in the summer, and it depends on how many people sign up and are willing to do that home tracking piece and really share their data with us. So it's an open platform, Folia. It's in the resource section. You can get on it now, take a look at it, and we'll put out the call for the study. So for us, it's really about getting enough people to have enough power to say something. So it's dependent on the folks joining the platform and doing some of that home monitoring.
One thing I'll just wrap up on this by saying, Jackie, is that while we won't have the result of the study for a while, the study is built such that those who say are randomized to stop a therapy in Simplify, at the end of their participation, whether or not they go back on that drug is left up to them and their provider. We're not implying that no one will be allowed or shouldn't change anything that they do in decision making with their families and providers until we have those results. We just think those results will be important to really understand the question.
I think I'm taking it all in. It's a lot to digest, but I think we're getting it all out there. Now, here's a question, probably for Kathy. So, which clinicians, or I should say, members of the clinic team, have you found most interested in reducing the treatment burden?
Oh, that's an interesting question. We haven't analyzed our data to look at it by role that I reported out. We did have a lot of physicians report in that Indiana study and clinical coordinators, but it was interesting to me that as a collective, the clinicians were more interested in reducing that burden than the patients and families were. So when we tease it out by role, I think that'll be an interesting question. I think my hunch is it'll be the pharmacists and physicians, but I want to stay sort of in equipoise until we take a look at those roles.
Is the data from the HERO study being shared with the clinic teams?
Yes, it is. It is. And it's available if you are on the platform. You can take a look at the data that came out of the study as well. They put out a report, the Folia put out a report about it. So yes, and it was shared back with the clinical teams. Mm-hmm.
Wonderful. All right, it looks like we're going to switch gears just a little bit again because we got a new question from the Q&A, and they've noticed that Trikafta has caused weight gain when they don't really need the weight gain. They feel they're already overweight and they're trying to lose weight. So would starting Trikafta undo their hard work? And this person does not take enzymes, is what was pointed out.
Yeah, I'll start, Kathy, but please jump in. It is apparent that people who start Trikafta often gain weight, and for the large majority of them, that's desirable, right? They're improving their BMI or their nutritional status back toward the goal, which is 50%, or the average in the population. It is also true that some have found that they go beyond that and they gain weight that they would prefer not to. People who are pancreatic sufficient and have CF, many of them do not have complete pancreatic function. They can get by without enzymes, but it is likely that Trikafta further increases their pancreatic ability to some degree, perhaps by affecting that pH balance or that acid-base balance in the intestine. So they may be getting some intestinal benefit, so to speak, from that others are seeing, even though they don't need enzymes each day. What I can say is that I think people with CF increasingly, as these drugs become more effective or start early in life, are going to be like those of us without CF, and that it's a constant battle to maintain healthy body weight, right? And diet and exercise and other approaches are probably necessary. My hope, though, is that Trikafta helps people gain energy and sleep better and have less respiratory limitation and can engage in things like regular exercise more easily and with more enjoyment.
I'm right there with you, Dave. We always, for the longest time, working in CF and being a mom, we always strived for normal is normal, right? Getting our kids to gain weight, getting them up to a normal height. And now to see with these new modulators coming on that we might have what normal people battle every day. Oh my gosh, right? You have to go out and exercise and maybe eat a healthy diet and not necessarily all the high fat calories. I think it's an adjustment that we're starting to see in our community and across people who are going on all the different types of modulators that are available. So that's all I know from an anecdotal point of view is, wow, different problem now.
I can fully agree with that one. Totally anecdotal, but yes, I did not believe in the Trikafta gain until I gained the Trikafta gain like that. So yeah, I've been doing, but now that my lungs feel better, I can go on those longer walks and I can, maybe reduce the amount of McDonald's I have each week and control and be normal a little bit, which I guess you should be careful what you ask for.
Exactly.
Now, we have another question coming in that I'm not sure we're going to be able to answer, but I'll throw it out there. Somebody had asked if there's studies or future studies looking at taking lower doses of Trikafta, especially with those who are having side effects.
That's a great question. I don't know. I'm not aware of any at this point. I think we just got people all on these modulators, and now we're more, from our point of view, I'm working with Elisa Fink at the foundation and some other adults and people with CF. It's really around the burden. We haven't really talked about the clinical aspect of dosing. Dave, do you know any more about that?
Yeah, this is not an area that I focus on, but I will just comment and say that when doses are selected and by companies that are developing new therapies for CF, there is a phase where they test a number of doses. And then in this case, they settled on one dose that they thought was the best match between safety and efficacy or benefit. There is some work being considered to try to understand if the way people may process these drugs, meaning their individual pharmacokinetics, may have something to do with how much they benefit or don't benefit. And so getting at a little bit of that question of does one size fit all here? Can one dose really provide what all need? It is a challenge, though, when the large majority do fine on a single dose, to then find a way to give a different dose at an individual level. That's pretty difficult to do. In other words, individual pharmacokinetics might be needed. And so I wouldn't hope to see that kind of gain in the short term, but there is work or research to better understand that process.
I knew that one was a long shot to answer, but I had to throw it out there because
that was a good, very good.
That's why we have Q&A.
That's a good question.
Yeah. Very good question. Yeah.
We did have another question in relation to blood sugar. So anecdotally, because I know it may not be studied yet, have you seen blood sugar being more under control after starting Trikafta?
Kathy, have you heard anything about that?
I haven't heard anything about that necessarily. And again, the data that's available to us is through the Folia app. We could, if there are people that are tracking that through that app, we may be able to look at some of that, but at this point, I haven't heard anything.
Yeah. PROMISE will include some very comprehensive glucose tolerance testing before and then after Trikafta to get a sense of whether or not people can process glucose and glucose challenges better or differently afterwards. But I don't know of any clear data yet saying whether or not this makes a real difference. You do hear of occasional reports of people needing less insulin or having lower highs, but some people have lows. So I think we still have more to learn about that. It seems plausible that there could be some improvement there.
It's good to hear that it's even being talked about and considered, since sometimes we forget to tell our clinicians everything and they don't know what's important to us. So I like
Yeah.
having it out there. It
And I was
looks
going to
like
say, this group of people should join Research Voice.
Right.
Great
exactly.
ideas are coming in. Just, the foundation and that the community partners and Research Voice, great way to add your ideas.
Yeah.
We definitely have had some great, great questions tonight. So it looks like we're getting close to the end. So we're probably going to do our last one, maybe two questions here. So let's I think end with this one. So the question is, as a parent of a 2-year-old on Orkambi and a 6-year-old on Symdeko, do you feel like Trikafta will be the best modulator for their life? I haven't seen much other research past those, so very curious. I know me personally, I did best on Trikafta, but I know a lot of other people have had varying results on the different ones. So this is another one I'm not sure we can answer, but let me hear your thoughts.
Yeah, just there was the study that studied 12 and older who went from Symdeko to Trikafta, and they had significant improvements in that transition. So I think odds are that an individual who's a candidate for Trikafta will do better than they've done on the two drug therapy. Worth noting, Trikafta is simply Symdeko plus one more drug influence.
I would agree with what you're saying, Dave. I know my son went from Symdeko to Trikafta, and it was a remarkable transition. So I can only hope that for your kids it's the same experience. It has really been life-changing.
Yeah, that's great to hear. Yeah. There was a question, Jackie, about mental health that got a lot of likes, and we're slow to delve in areas we don't know well. So mental health might be one of those for me. But I would love to know, Kathy, if there's any work being done in the more real world research to better understand, impacts on mental health improvements or otherwise. And I would hope that even during this pandemic, those who have benefited from Trikafta perhaps had a little less stress than they may have had before they went on that drug.
Yeah, certainly within the data that we collect, you can report like your daily mood. Did you have a good day, bad day? It's sort of on that level. We're not asking formal, mental health screening or anything like that, but we're looking for more general mood, less anxiety, happiness sorts of measures. So I think we'll start to see some of that. Mm-hmm.
That's great. That's great.
Yep.
I have heard of more experts in mental health too, starting to try to organize around some more battery assessment kind of stuff.
Right.
I don't know about brain chemistry, which was mentioned in the question. That's another step entirely. Yeah.
Yeah.
And Kathy, I'm really glad because I did look at the Folia app and participate in part of that study. And I like that you could also show if your symptoms were worse because of this. So I know there's anecdotal thoughts, anecdotal things, I can't think of the word, that show that actually some people are having increased anxiety and depression. And is it related to Trikafta? We have no idea. But at least you can track that and watch it. So I'm really glad you guys are on top of that because I think that is important to a lot of people.
And I think what's nice about it is reporting it to your team. You can share it with your team. And when you come to a visit, you have that information available to them. What's been happening since the last time you spoke?
And that is a great place to end because unfortunately, my friends, we are out of time. So I do need to wrap this up. I want to thank all of you and especially thank our speakers for sharing your knowledge and insight about the changing care, CF care with Trikafta. There are many wonderful researches out there related to the event sessions, including our own, in the research room, which you can access from the home page of the event, which again looks like a lab. For this session, if you go into that room, you will find slides we shared and other items and websites that the speakers thought you might find valuable. We encourage all of you to check them out and download anything you want to keep. So thank you for all your questions. Thank you for attending, and we will now take about a 5-minute break, after which I hope to see you all in the keynote room for a short closing event of tonight's festivities. Thank you again for coming to learn about the changing care in the era of Trikafta, and you can now all close your windows and return to the ResearchCon environment. Thank you all. Bye-bye.
Thank you.
Thank you, Jackie.
Have a good evening. Thank you.